I'll come back next year. All right, so I'm going to open by going back in history. My father was a lover of history and just books and books and books throughout the entire house. And so I learned to appreciate history. And going back in history, actually breast cancer is probably the first cancer that's been described, at least in written word. This is the Edwin Smith papyrus that dates back to Egypt around 1600 BC. It was discovered by Edwin Smith, a British man. And in the document, they're talking about treatment with cautery, a fire drill, or removal of tumors on the chest with sharpened instruments. Sounds like surgery and radiation to me. So hopefully I'll convince you we've come a lot farther. And shown here is Rudolf Ludwig Virchow. Virchow is the scientist who, back in 1863, published this 4-volume treatise that describes the tumorous diseases. And he used the microscope to classify cancers. He classified cancers based on the organ of origin. So if it started in the lung, it's a lung cancer. If it started in the breast, it's a breast cancer. And he looked under the microscope at the architecture of the cells to histologically classify how the cancer cells appeared, how they organized themselves. And actually, we're still teaching medical students the histologic classification. Shown on the left here is what's called an invasive lobular carcinoma, where the cancer cells are sort of stringy, like tentacles. They invade along other normal cells. They don't tend to make a large mass, and they're hard to pick up on imaging because of this spreading pattern. And on the right side, the most common type of breast cancer, an invasive ductal carcinoma, in which the tumor cells pile up on top of one another and actually makes a mass-like structure, and is the most common form, probably 80 to 90% of breast cancer. So that classification was helpful somewhat, but not really. And here is the classification system showing all of these rarer histological subtypes that are each about 1% of all breast cancer. And for some of these subtypes, it tells us a little bit about their behavior and how aggressive they are, or how to treat them. But for the majority of cancers, the histology doesn't distinguish a breast cancer that's likely to metastasize versus a breast cancer that's going to be slower growing and less dangerous. And now, thankfully, like in many cancers, breast cancer is moving away from a one-size-fits-all approach. And we're beginning to understand and appreciate in the last 3 decades or so that there are different flavors or subtypes, that breast cancer is actually a collection of different diseases. So you're not expected to understand what this picture is here. It looks pretty intimidating, but what it essentially is each one of these columns here represents one tumor type, and the tumors were taken in the laboratory and tested to see how all these genes, the genes are one gene per row, how the genes in the tumors expression relates to normal expression or a reference pool. So if a gene is overexpressed, then the dot turns red. And if it's less expressed than in normal cells, it's green. Actually, I think I have that opposite. But when you classify tumors based on molecularly what's happening under the hood of the car, you can see that the tumors now classify into different subtypes that now are associated with different prognoses. Shown up here is called a Kaplan-Meier curve. Everybody starts out alive, and then you follow over time, and you can see patients with the blue type of breast cancer, the luminal A, that are these patients here on the right side, these are the patients that have the best long-term outcome, the best long-term survival. But these patients here in the red or the purple, HER2-driven or basal-like, which tends to be triple-negative breast cancer, have the worst survival. So now we're learning something about the prognosis based on a classification that's different than just looking at how the cells look under the microscope. By the way, these data come from the pre-Herceptin era. So if you or somebody you know has HER2 positive breast cancer, do not look at these data and be discouraged, because these are much based on much older data. So we're moving away now. There's a major shift in how we're classifying cancers. We are not just looking at how they look under the microscope, but we're beginning to understand the molecular problems, the problem under the hood of the car that's making that cancer grow and divide. And that's allowing us to move from cancer treatments that kill all rapidly dividing cells indiscriminately to treatments that are targeted or tailored to what's going on in the car, rather than blowing up the whole engine, just replace the spark plug. So let's talk about HER2 positive metastatic breast cancer first. Earlier today, we had an amazing lecture by Dr. Dennis Slayman, and this is his paper that really changed the way that we think about HER2 breast cancer. In his paper, he showed that a portion of women, around 30% at the time he published this, have a problem in their tumor where there's too many copies of the gene for a protein called HER2. And that was shown by this southern blot here. Some of the cancers have too many copies. And then he went on and showed that if you look at the cells themselves and stain it with a stain that stains the HER2 protein on the cell surface, he shows when there are too many copies of the gene, there's too much of the protein on the cancer cell surface. And then he went on and demonstrated that the patients who had this alteration, this amplification of HER2, had a worse survival. They had a 50% shorter survival compared to women who had HER2 normal disease. And this was in stage 2 to 3 breast cancer. This was not metastatic breast cancer. Now, that realization that a subtype is associated with worse survival gives scientists information, but it doesn't give patients much hope. That's useless information to give to a patient. Bad news, your disease is associated with a worse outcome. That's called prognostic information. It's useless to a patient. What's useful to a patient is then demonstrating that that information is predictive of benefit from something, that you can do something about it. And that's what makes this story so special. So Slayman and colleagues actually took breast cancer cell lines in the laboratory that were normal for HER2, and he added the HER2 gene to them, making them HER2 positive, and then compared what was happening in those cells that were normal versus HER2 amplified, and showed all these things happen more frequently in those cells that are HER2 amplified. So that gave him information showing that the HER2 alteration had a cause and effect on cancer cell behavior. And he and colleagues went on and developed this drug, which you know as Herceptin, trastuzumab, which is this yellow molecule here. It's an antibody that is engineered to recognize the outside of the HER2 receptor. HER2 stands for human epidermal growth factor receptor number 2. So HER2 is a little easier to say. And when this antibody binds to the extracellular domain, it stops the cell from behaving in a malignant fashion. It has effects. It allows the cell to undergo apoptosis, which is natural tumor death. And it may also incite the immune system to recognize the cancer cells as foreign and kill them. And so this was his original paper, which actually was presented in 1998, showing that giving trastuzumab in addition to chemo to patients with HER2 positive breast cancer improves overall survival by 5 months. This led to regulatory approvals beginning in 1998 for this particular disease. And an important feature of this story is that he and his colleagues insisted that HER2 positive breast cancer be evaluated specifically. There were some scientists and people on the part of the drug company who wanted HER2 normal breast cancer patients to be allowed on the study as well. And that wouldn't have made any sense if this drug only worked in HER2 positive. So he won that fight. If you're interested in reading about that fight, it's a good short read written by former NBC News analyst Bob Bazell called HER2. So it's easy to remember, and it's a fascinating story. So the development of HER2 targeted therapy, we now know, fast forward 24 years later, has changed the natural history of this disease subtype. Don't get overwhelmed by the graph here again. Let's just focus on the table here. This is a collection that was published by the French Comprehensive Cancer Centers. There were 18 comprehensive cancer centers in France that they decided to follow every woman diagnosed with metastatic breast cancer starting in the year 2008, going on through 2015, 2016. And they had to be women, they had to have metastatic breast cancer, and you had to know what subtype it was. And then they looked at how long patients lived based on which year they were diagnosed. I'm just showing you the data for the 4,000 or so patients who had HER2 positive breast cancer. And what you can see is in 2008, a woman diagnosed with metastatic HER2 positive breast cancer had a median overall survival expectation of 39 months. Median means half the patients were alive at 39 months, half had passed away by 39 months. And look at what's happening to the number year after year. Those numbers keep going up such that in 2013, the median overall survival for a woman diagnosed that year was 58 months. And in subsequent years, we haven't even reached the median, meaning a woman diagnosed in 2014, more than half the patients are still alive. So that patient population is doing better and better, and these numbers are now better than what we see for HER2 negative disease. So this discovery has swapped that prognosis I showed you early on, where it was one of the worst outcomes, to now being one of the best outcomes. And it's also due not only to trastuzumab, but to the next generation of molecules that came. In the US, we have 8 FDA-approved HER2-targeted therapies available for our use for our patients with HER2-positive metastatic breast cancer. There are 3 monoclonal antibodies like trastuzumab, pertuzumab, and margetuximab. There are 3 drugs that are given as pills, lapatinib, neratinib, and tucatinib, that have been approved. And then there are antibody drug conjugates that I'll be talking about, TDM1 and TDXD. So in the first line setting, when I say line, I mean a patient comes to clinic and has never received treatment for metastatic disease. That's the first line. The standard of care in most of the world, where available, is giving a chemotherapy, taxane, plus 2 antibodies, pertuzumab and trastuzumab. So what is this pertuzumab? I just told you what trastuzumab is. Pertuzumab actually, interestingly, was being developed in the same company, Genentech, that was developing trastuzumab, and it didn't look like it was going to work as well in humans. So it was kind of put off to the side for a while. And then scientists there began to play with it to see if it would work with trastuzumab. So what I'm going to pause for a moment and go to HER3. HER3 is another receptor. There are 4 receptors, HER1, 2, 3, and 4. HER3 gets activated when a ligand, a protein, binds to the HER3 on the outside of the cell. This induces the receptor to do what we call a conformational change. It unfolds. And that opens up this binding site here, where HER2 can bind to it. The only way HER2 gets activated is by binding with another receptor, and its preferred partner is HER3. And HER3 has a ton of docking sites for PI3 kinase. And so when HER3 and HER2 get together, that sets off an explosion inside the cell, a signaling pathway that allows the cell to divide and grow and stay alive. So what pertuzumab is, it's an antibody just like trastuzumab, but it binds to and blocks where the two HER2 and HER3 get together, and it's a different site than where trastuzumab binds, which is somewhere over here. And so studies were done in mice and then in phase 1 showing the two drugs, the two antibodies work well together. And this study was designed, Cleopatra, looking at trastuzumab and chemo, docetaxel, with pertuzumab compared to just the trastuzumab and chemo. And in this study, patients only received the chemo for 4 to 6 rounds, and then they dropped the chemo and continued the pertuzumab and trastuzumab, which is pretty easy therapy in the scheme of things. Your hair grows back, you don't have a low white count, generally well tolerated. And this is what they showed. Now I'm going to show you Kaplan-Meier curves. So I'm going to, if you're not familiar with these, I'm going to explain it for a minute. So in this study, the blue curve is the patients who received the control arm. They didn't get pertuzumab. And again, if you look at the 50% mark, where 50% of patients are alive and 50% are not alive, or alive without their disease growing, or their disease has grown, that corresponds to a 12.4 month time. So we say the median progression-free survival for patients who didn't get the pertuzumab was 12.4 months. And if you look at the median progression-free survival for those who did get pertuzumab, it was 6 months better. It was 18.7 months. Not only was the PFS better, but the overall survival was better, as shown here. 57 months, which was over a year greater than patients who did not get pertuzumab. So very impactful data. And this has been the regimen, the gold standard regimen to use in somebody who is previously untreated with HER2-positive metastatic breast cancer for a decade. I think it may be bumped soon. Mark my words. Next year we can talk about that. But you can see here this progression-free survival is really the highest that had been seen in a long time when you compare it to other clinical trials, which is why it remains the gold standard. Now, what happens? Now, it doesn't cure patients. Unfortunately, we're not curing the majority of patients. John and I talk about, the likelihood that there are some patients who are cured. It's hard to identify who actually won't have their disease progress. The majority of patients with HER2-positive disease will have their disease become resistant to the first therapy. And so we'll have to switch or pivot to a new therapy. And that's called second-line therapy. And the standard second-line therapy for about 8 years was this drug called TDM1, also known as Kadcyla or trastuzumab emtansine. And it's pictured right here, this purple molecule. It's essentially trastuzumab or Herceptin, and loaded onto it are 3 to 4 chemotherapy molecules. And it's very smart because you load the antibody with these chemo molecules, and the chemo doesn't actually become active until it's bound to HER2, taken up inside the cancer cell, and then that chemo is released and the cancer cell is killed. So the idea being it's a smart bomb. It goes directly after the cancer cell, sparing normal cells. This study led to the FDA approval of TDM1 in 2013. It's available many places in the second-line therapy setting. It does improve survival compared to standard of care chemo and a drug called lapatinib, which is an oral drug. However, and you can see here the progression-free survival was quite good with this agent. However, recently, this drug here on the left has hit. And this too is an antibody in the blue, but loaded with more molecules of chemo and a different type of chemo. This is called deruxtecan. It hits a different part of the cancer cell. It's very potent. And it also, one feature of this chemo is that it can leave the cancer cell. It's able to, it's membrane permeable, so it can go out of the cancer cell and kill neighboring tumor cells that may have lower expression of HER2. That's called a bystander effect. So this drug was tested against TDM1 in a randomized clinical trial. Patients, half of them got TDXD, half TDM1, and patients were followed to see how long their disease remained controlled in each of the arms. All of the patients had to have previously received trastuzumab and a taxane, and their disease had to be resistant to it. It had to have grown on that. And these are the results that we're seeing. Really phenomenal difference in the Kaplan-Meier curves, and you can march out the 50% time point here. For TDM1 was 6.8 median per month, median progression-free survival, and for the TDXD arm, it hasn't even reached the median time yet. Very exciting data, indicating that it has a 72% better progression-free survival compared to TDM1. And it looks like overall survival, how long patients live, period, end of sentence, is trending toward better. There were fortunately very few patient deaths at the time of reporting. This data will continue to mature. And we saw that nearly 80% of patients treated with TDXD had their disease shrink or disappear. 16% of patients treated with it had it disappear. You couldn't see the cancer anymore on scans. And all of these numbers compare favorably against TDM1. So immediately, where available, these data made TDXD the standard of care in the second line setting. And the reason I said earlier that I think the Cleopatra regimen, the HP, the THP regimen is going to be threatened is because these data in patients who are more heavily pretreated, they had resistant disease, look just as good, if not better, than the data from Cleopatra. So there's an ongoing clinical trial now where TDXD is compared to that Cleopatra THP regimen. So what about the third line setting? The other molecule I'll talk about for HER2 positive is tucatinib. Tucatinib, small molecules, there are three of them I mentioned, neratinib, lapatinib, and tucatinib. There are other ones being developed in China, predominantly pyrotinib and poziotinib. These drugs are pills. They get in and they don't act on the outside of the receptor, they act on the inside of the receptor. But when you make a chemical compound instead of a engineered antibody, it's hard to make that compound specifically inhibit only one target. So what you get is inhibition of other similar targets, and that can lead to toxicity. So lapatinib, neratinib, pyrotinib, poziotinib, they all hit HER1, which is known as epidermal growth factor receptor, to a great extent, and that can cause diarrhea and rash, and it can be very significant. Tucatinib is unique because it was engineered to be more selective in its ability to inhibit HER2, so there's much less inhibition on HER1. Moreover, it's also able to penetrate quite well that blood-brain barrier, allowing the molecule to get into the brain and treat disease or prevent disease there. So a clinical trial was developed called HER2CLIMB. This was a really important clinical trial, not just because of what the results were, but because the design was one of the first of its kind in that they allowed patients on the trial who had active brain metastases, meaning brain metastases that were growing at the time the patient came on the study or that had never been treated with radiation or surgery. And 48% of patients on this study did have brain metastases. Usually studies did not allow patients with brain mets because drugs have a hard time passing into that brain. So in this study, all patients received Herceptin and Xeloda or capecitabine, and 2/3 of them also received tucatinib. And you can see here the progression-free survival was significantly improved by over 2 months by using tucatinib. It also improved in patients with brain metastases, and it improved how long patients lived, which is, of course, our most important endpoint, is making patients live longer with this chronic disease. The other data that I haven't shown you is in the patients with brain metastases, we saw an improvement in their overall survival, and nearly half of them had shrinkage of the brain metastases. So it really is quite active and has become, in many parts of the world, a standard of care available for patients. The T-DXd drug has also been evaluated in this heavily pretreated patients population. As I showed you in the DESTINY-Breast03 trial, phenomenal results. These are actually the first results we ever saw. This is what's called a waterfall plot. So each one of these bars represents one patient and what their disease did while on study. So here we see 4 patients whose disease best response to T-DXd was growth. The rest of all of these patients experienced some level of disease shrinkage, with 62% of them having at least 30% reduction in their tumor volume or a complete response. So in the US, this drug was made available in 2020 based on these early data. So as I leave the HER2 space, I'll just let you know, this isn't the end of the story, it's just the beginning. We are seeing the survival take off. I have patients in my clinic who've been living 15 to 20 years with metastatic HER2 positive disease. And this is just a short list of molecules that I pulled to give you an idea of what is in clinical trials for this specific disease. Molecules that target multiple receptors at the same time, new antibody drug conjugates like TDM1 and TDXD, and immune-based therapies, just to name a few. So now I'm going to turn to the most common form of breast cancer, which is known as hormonally driven or hormone receptor positive breast cancer. Sometimes it's called ER positive, estrogen receptor, or progesterone receptor positive disease. And back to history, love history. Shown here is a picture of George Beatson. He is a surgeon. His father was actually I just looked this up today. I wanted to brush up on the history. His father was actually the physician for Queen Victoria. But he's a Scottish surgeon, and in 1896, he published this article in the Lancet shown here. And what he did was he removed the ovaries from a young woman who had a very recalcitrant, aggressive breast cancer, and the breast cancer regressed by removing the ovaries. And he did this because he spoke with farmers in the area who said, if you remove a cow's ovaries, it leads to prolonged lactation. It's something that was being done in many different farming communities. So there was this link between the ovaries and the breast tissue. So he did this experiment and her disease shrank. He did it actually with 3 patients and saw some very dramatic results, published them here. But what wasn't published here is that when he did it on a larger scale, only 2/3 of women had their disease regress or shrink. And why is that? Now, at the time, they didn't even know about estrogen, and that estrogen was created by the ovaries. The estrogen receptor hadn't even been discovered until 1968, but he used this observation and tested it, and it worked. And now we know only 2/3 of breast cancers express estrogen receptor, and that's why he saw this in the clinic. So now we don't have to remove ovaries from all our patients. There are drugs that we can use to interfere with the relationship between estrogen and breast cancer growth. Estrogen receptors are simply shown here as blue receptors. I think of them as a lock and key. When 2 receptors are each engaged by estrogen, they leave the cytosol, they go into the nucleus, and they actually turn on genes in the nucleus of the cell to make the cell grow and divide. And so you can either take tamoxifen, which blocks that receptor and doesn't allow the key to get in the keyhole, or you can take drugs like aromatase inhibitors that block estrogen production in women whose ovaries are no longer functioning, or you could take something like fulvestrant, Faslodex, which blocks the estrogen receptor. And so Here's just a timeline here. Vincent's discovery in 1896. It wasn't until really the 80s that drugs like tamoxifen began to be used, and large trials showed their benefit, then aromatase inhibitors, then fulvestrant. And really in the last decade, we're having an explosion in research on other ways that we can go after that hormone pathway and related pathways to improve outcomes. And one of the biggest discoveries came out about 7 years ago now, again from Dr. Slayman's laboratory, and it's a therapy that targets something called the cell cycle checkpoint. Every cell in our body needs to have very regulated timing of when that cell can divide from one cell into two cells. So you'd imagine if your cells were just all dividing at the same time, we'd be one big tumor. And so the way that that is controlled is by a protein called retinoblastoma at the R point. The cell isn't allowed to go into cell division unless it passes that point. And one of the regulators of that point is called cyclin-dependent kinase 4 and cyclin-dependent kinase 6. These two enzymes will basically hyperphosphorylate. They will turn off that retinoblastoma protein, say, get out of the way, and the cell cycle is able to proceed. In cancers, it is known that this checkpoint is broken in a lot of cancers, including breast cancers. And so scientists developed a drug, a pill called palbociclib, that blocks CDK4 and 6. And in Dr. Slayman's laboratory, he took cancer cell lines, all of these, each one of these bars is a breast cancer cell line. Some are ER positive, some are triple negative, some are HER2 positive. And he treated them with the palbociclib drug to see how they work. And you can see on the right side, these cancer cells keep on growing. They're very resistant to palbociclib, and there are some with intermediate sensitivity, and then on the far left are cell lines that are exquisitely sensitive. They die, they stop growing in the presence of palbociclib, and when he took a peek to figure out what cell lines are sensitive to it, it turned out they were all that luminal or hormonally driven breast cancer subtype. And that discovery led to a clinical trial, a phase 1 clinical trial that opened just as I was starting as faculty. I enrolled a couple of patients on this study. One of them is this patient right here. Each of these bars represents a patient. There were several patients who had disease shrinkage, 3 shown here. The data was so promising when you give the drug with an aromatase inhibitor. We're seeing really nice responses. And actually, this is her. This is Janet. She gave me permission to share her story and picture with you. She was 49 when she was originally diagnosed with stage 1 cancer, and she had mastectomy and tamoxifen. And then by the age of 53, develops metastatic breast cancer. She started on this trial. And she, at the point I did this, is now age 64, but she's now close to 15 years, and her disease has not grown. She remains on first line palbociclib and letrozole. She's seen her daughter's wedding. She's seen 2 grandchildren born. This is the partnership that we have with our patients, is how we get new drugs to the clinic and how the field advances. So a big shout out to her and to everyone who participates in trials. This promising data led to a phase 2 randomized trial where half the patients didn't get palbociclib, they got just letrozole, and half got both drugs. And you can see again a very wide separation in the curves, indicating that if you take palbociclib, you double how long the time that your disease is controlled. So you're not expected to, I won't quiz you on this afterwards, but this is a table now of all the clinical trials that have been done, that have enrolled thousands of patients, 666 in this trial, 668 here, where half the patients got just endocrine therapy and half got the anti-estrogen therapy with the CDK4/6 inhibitor. You can now see there's ribociclib and abemaciclib. There are 3 of these agents. all of them significantly improved how long women would have their disease controlled, on the order of 50% improvement, meaning doubling the time that they live without their disease getting worse. And now data coming through that women are living longer. Again, the gold standard is show that we are improving how long a woman lives. And we're showing you may not need chemo. You can really delay when you need to give a woman with hormone receptor positive breast cancer chemo. It used to be when I was trained, you know, if you have a patient come in, she has liver mets and she's symptomatic and lung metastases, if you want to get a good response quickly, you give chemo. Chemo haphazardly kills all rapidly dividing cells. You'll lose your hair, you don't feel well, your white count can drop. But everybody, there was this sort of thinking that you had to give chemo. And what I've done here is show you the percentage of women who have their disease shrink or disappear with the CDK4/6 inhibitor trials compared to all these chemo trials. You don't need chemo anymore. You can do a CDK4/6 inhibitor and get the same or better type of response. And the progression-free survival is historic. Now we're seeing used to be less than a year before a patient's disease would progress. And now it's out to 3 years that patients are living without their disease getting worse, without needing to switch to a different therapy. What happens after a patient's disease has become resistant to the CDK4/6 inhibitor? Well, we're now using a lot of drugs that are targeting this pathway called the PI3 kinase AKT-mTOR pathway. This is a signaling pathway. It's proteins inside of the cell that are involved in making the cell resistant to these agents. And so we have an inhibitor called alpelisib or Piqray, and an inhibitor called everolimus or Afinitor that targets this pathway. And we can use these drugs based on understanding the patient's tumor gene. We can do a test based on blood to pick up the circulating tumor DNA and see if that tumor has a mutation that's activating that PI3 kinase called a PIK3CA mutation. And if it does, you give the alpelisib, and if it doesn't, you can give everolimus. So we're becoming smarter about how to determine therapy for patients. It's not just try tamoxifen, try an AI, and if that doesn't work, go to chemo. We're beginning to be able to look at what's happening under the hood of the car to see what needs to be fixed. Another area that you may have heard of that's really exciting is this new sort of subclassification of breast cancer called HER2 low breast cancer. Now, I told you earlier it was sort of where you are, is your disease HER2 amplified or is it not? It was a very binary yes, no. But now with drugs like T-DXd, which are the Trojan horses, they can target chemotherapy to a HER2 expressing cell. You may not need to have substantial overexpression of HER2 in order to get the chemo to the cell. You may just need a low level of expression. It turns out about 2/3 of hormone receptor positive breast cancer and 1/3 of triple negative breast cancer is HER2 low. And so we know that T-DXd, this drug that I showed you earlier, not only eradicates HER2 positive tumors, these are tumors that are HER2 positive and HER2 negative. If you treat it with T-DXd, it kills also the HER2 negative tumors, the non-amplified tumors, because of that bystander effect, because the chemo can leave the cancer cell. So there was this study, this just came out 3 months ago. It's pretty much hot off the press, called Destiny Breast 04, in which patients who had low level expression of HER2 on their tumor and had already had their CDK4/6 inhibitors and hormone therapy and 1 to 2 lines of chemo received either T-DXd or single agent chemotherapy. And they close to 90% of the patients on the study had hormone receptor positive disease, although they were allowed to have some patients with triple negative breast cancer. And the patients were, about 60% of them had received 1 prior line of therapy and 1/3 had received 2 prior lines of therapy in the metastatic setting. So this is 3rd line study for many patients. And again, you can see this very nice improvement in progression-free survival in the hormone receptor positive patient population and all patients combined together. But again, overall survival was significantly improved by, gosh, more than 6 months, a 6.4-month improvement in how long patients live by getting this Trojan horse sort of antibody drug conjugate, TDXT. So this is very practice changing and available to patients in some countries now, if they have HER2 low expression, and over 50% of patients had their disease shrink. Look at the objective response rate with giving chemotherapy alone, very low. So having it shrink or disappear is a meaningful endpoint as well. It feels good to patients. It helps them be less symptomatic from the chemotherapy. Another antibody drug conjugate that has recently had data come out is sacituzumab govitecan, known as Trodelvy. This is an antibody. It doesn't target HER2, though. It targets something called TROP2. TROP2 is expressed in all types of breast cancer, and it's loaded with a chemotherapy similar to the one used in TDXD. And this study, the TROPiCS-2 trial, was a phase 3 study in patients who were pretty heavily pretreated for their metastatic disease, and they were randomized to receive the sacituzumab or chemotherapy, very similar study design. And we see a nice improvement in progression-free survival. Only about a 5-week improvement in progression-free survival. We're really greedy in the breast cancer realm. In pancreatic or lung cancer, they'd be getting a standing ovation. For us, we're like, you know, can you show us something better? But what is good is that 2 weeks ago now at the European Society of Medical Oncology, overall survival was reported, and it was improved by 3 months with the use of sacituzumab. Again, I think this will quickly make this drug a standard available drug in patients after their endocrine therapy has stopped working for them, after they've had chemotherapy. So you can see this graphic I showed you earlier is getting more crowded with these therapies that are available. And I think what we're going to start seeing is data come through from like the French group showing that we are budging that median overall survival with the use and implementation of these new targeted therapies. And so for the last bit of my lecture, I'll just hit on triple negative disease. Triple negative disease represents somewhere around 15% of all breast cancer. And I got to admit, you know, we talked today at our other conference about this. It's not a very elegant way to define a breast cancer classification. Here I'm telling you how we're getting smarter about this, and we're defining it by what it is not rather than by what it is. And it is actually heterogeneous. There are subtypes within it. We know overall, in general, it tends to grow very quickly. It paradoxically seems to be quite responsive to chemotherapy, but then recurs more quickly. It has a different pattern of metastases, often in the viscera, liver, and brain, and has shorter median survival. It also tends to affect younger women and Black women as well. You can see here that these are patients with early stage breast cancer. If they have triple negative, they have a high rate of recurrences in the first 5 years. And then after that, it is very rare to have a recurrence. So if you have early stage triple negative breast cancer, you know in the first 5 years, usually, if it's going to come back, whereas ER positive breast cancer can come back many decades later. And this just underscores that the survival associated with triple negative breast cancer in the light blue here tends to be worse stage for stage at diagnosis. We are moving the needle on this here. We are beginning to break through. There are a lot of work from scientists to define molecular subtypes with a lot of therapies that are making breakthroughs in outcomes for patients with this disease. We have immune checkpoint inhibitors. We have PARP inhibitors that for now are available for BRCA1 and 2 germline mutation carriers. And we have those antibody drug conjugates I told you about earlier available for metastatic disease in some areas of the world. Immune therapy is something that has had a lot of successes in other types of cancer. Breast cancer is sort of the last to the game here. Triple negative breast cancer is probably the most likely to have benefit from immune therapy, and that's where we're using it only. We know that triple negative cancers do have T-cell infiltration, as well as expression of a protein called PD-L1. This is what should normally happen here with a T cell. A dendritic cell will come up and present an antigen or a protein to a T cell and say, hey, recognize this, and generate an immune response against it. And the T cell makes more of itself. It goes out and it looks for this foreign body. And then when it comes across that antigen on the cancer cell, it kills it. Our immune system has a lot of checkpoints, though, that block our immune system from attacking normal cells. And what cancer cells have done is they have an ability to evade the immune system by turning on these receptors like PD-L1, et cetera, to tell the immune system, hey, I'm one of you, don't kill me. So therapies are being developed now to block those immune inhibitory signals. And one of the only one that is approved now for breast cancer in the US is pembrolizumab. In some parts of Europe, atezolizumab is still available. But again, these are antibodies, just like trastuzumab. They turn off the off switch on the immune system to allow the immune system to rev up. If you rev up the immune system, what's the side effect going to be? Autoimmune problems, right? So they have unique side effects that need to be considered. The study that led to the approval of this drug, pembrolizumab, in metastatic triple negative disease is Keynote 355. All patients received chemo. 2/3 also got the pembrolizumab, and they were patients in the first-line setting for metastatic triple negative disease. And you can see that in patients who had high expression of PD-L1, there was real benefit. 38% of patients did have high expression of PD-L1, and so it was approved there, but with lesser expression, it didn't show that there was a statistically significant improvement. The overall survival was also improved in patients with high expression of PD-L1. And so that's where immune therapy is in metastatic breast cancer. We did briefly have atezolizumab available to us, but the confirmatory trial was negative. So at least in the US, the approval has been withdrawn. And there are a number of ongoing studies seeing if we can more effectively harness the immune system to kill triple negative cancer and other cancers. I told you about Trodelvy, sacituzumab, and hormone receptor positive breast cancer, where the first place it was tested was in the ASCENT trial in triple negative disease. Patients received sacituzumab or single agent chemo. The progression-free survival was substantially better, now on the order of 4 months better. And look at those patients getting chemo alone. Half of them had their disease grow in less than 2 months of being on therapy. So it just shows you how ineffective chemo is. And importantly, the overall survival was nearly doubled by using sacituzumab compared to chemotherapy. And T-DXd, I told you about use in HER2 low. There was 10% of the patients in the Destiny Breast 04 trial had triple negative HER2 low expressing breast cancer, and T-DXd looked better than chemotherapy. So the problem is it doesn't have as many patients in that cohort. The data is not as strong as the data is for ASCENT with sacituzumab, but these are very intriguing data and are being confirmed in ongoing clinical trials. And then finally, PARP inhibitors. PARP inhibitors work against DNA repair. So all of us are exposed to external factors that cause breaks in our DNA. Plus, you can get normal physiology. You can have breaks in your DNA. And so we have these pathways that are implicated, these proteins in our cells that are able to repair those DNA breaks that damage the DNA. And the homologous recombination is virtually error-proof, and it is controlled by BRCA1 and BRCA2 proteins. So if you have a gene that you've inherited from mom or dad, in BRCA1 or 2, you only have one normal copy of the BRCA gene, and normal cells are able to repair themselves because there's enough protein being made. But if a second hit happens in a breast cancer cell, for example, then that cell no longer can repair the DNA repairs, and it goes to a backup pathway called base excision repair, which is controlled by an enzyme called PARP1. So if you inhibit PARP1, you can actually turn that cell into such a dysfunctional cell. You're turning essentially a three-legged table into a two-legged table. The cell dies. And it won't kill, PARP inhibitors won't kill cells that have normal or enough of the BRCA protein to be able to function. So this idea is called synthetic lethality, where you take the drug and it specifically targets those cancer cells that are deficient in this DNA repair pathway mechanism, sparing normal cells. And we have two studies, one's called Olympiad and one's called Embraca, that led to the approval of two PARP inhibitors, olaparib or Lynparza and talazoparib or Talenza. And both studies showed that if you take this pill, a PARP inhibitor, and you have a germline BRCA mutation, you got one from mom and dad, or dad, then your progression-free survival is about 3 months better than using chemo alone. Not a home run and no difference in overall survival, but these are pretty well tolerated agents. And so they're being evaluated in combination with other treatment strategies. And they're also being evaluated in non-germline BRCA mutated cancers. So this is how the paradigm is shifting for the treatment of triple negative breast cancers. It used to, when I started, just be chemo. That was your option. And now we have antibody drug conjugates, we have immune therapy. For some patients, we have PARP inhibitors, and we have a lot of clinical trials and new agents that are being tested. And so with that, I know I talk fast. I can open it up for some questions.